to ensure that we recognise that all of us, unless we're meeting outside of Australia, are meeting on First Nations land. And we recognise that those of us in Perth are meeting on the land of the Whadjuk people of the Noongar Nation, and we acknowledge the significant contribution, the huge contribution to not only caring for the lands on which we are, but also the cultural leadership provided by elders past, present, and those who are emerging, and also recognise that this is not just a matter, appropriate matter of respect in this acknowledgement, but also acknowledging the huge role that First Nations people play in the work that we do at NDRI. And in fact, in the work that we all do in terms of our prevention effort across the country. So whilst we acknowledge the land that we're on here in Perth, we also would hope that you take a second or two to recognise the land and acknowledge privately, or if you're in a group, amongst the group, the lands that you're actually on across the country. This project is part of a range of cost studies that we've been supported to undertake by the Department of Health, the Australian Government Department of Health. Previously, we've done work on methamphetamine, on cannabis, on tobacco, on opioids. And so we encourage you, if you want to look at the full reports, you can go to our website, and there will be links shown that will take you to the particular website to actually see the reports in full and to see the detail of the methodology. Why did we do this? Well, it's some time since there were the last analyses of the costs of alcohol were undertaken. And clearly, as many of us are aware, there's been changes in the patterns of alcohol use. In some respects, there's been significant downward trends in consumption in Australia, largely driven by changes amongst young people, not so much people in my age bracket. We have emerging evidence about the impact of alcohol on various conditions, and so the evidence has actually increased our understanding of some of the adverse consequences of alcohol use that previously weren't available. And for example, significant increases in the evidence about the impact of alcohol on cancer. We're also aware, and indeed some of our team have been significantly involved in the critiques of the alleged benefits of alcohol, which have figured very strongly in some of the previous assessments that have been undertaken. We can only, in our work, identify costs where there's clear evidence. And due to the delay in some data, for example, coronial data can take some time to come through, we ended up selecting the most recent year where we could get the most complete data. And you'll hear more of that. But the costs that are there relate to a whole range of issues. They relate to impacts on individuals, but they also relate to impacts on communities. The costs related to health, to road safety, to the justice system, and of course to workplaces. But we also note in our report that there are significant gaps in the knowledge that don't allow us to make cost estimates. And one clear example of that is in relation to the effects of fetal alcohol spectrum disorders, where we know that the costs are likely to be significant because the costs are lifelong. But because we don't have sufficient data about prevalence, we couldn't with confidence make estimates, although some suggestions are that it's up to $16 billion. We can also recognize that there are likely to be significant costs for those who live with someone with alcohol dependence, but we aren't able to estimate that. The costs of someone who turns up to work from previously drinking, who are at work but aren't contributing as much as they should or contributing at all to productivity. We weren't able to make estimates of those costs in our report. So that tells us that this is likely to be a conservative estimate. Despite those omissions, our conservative estimates are that the costs of alcohol are not far short of $67 billion. And the consequences of this are felt in human terms, the over 5,000 alcohol-caused deaths, for example. And of course, the cost affects a large proportion, if not all, of the Australian population, including those who don't drink. The huge toll on parents, the huge toll on partners and or friends, on work colleagues, in terms of the distress and the emotional impact, isn't adequately covered by a dollar figure, and we recognize that. It's clear that alcohol does not just have an impact on a few heavy drinkers who are alcohol dependent. It can affect our emergency departments. It can affect our road safety. It can affect, therefore, the insurance we pay for our cars. It can affect the well-being of our children. It can affect the well-being of our friends and communities. It contributes to some of our largest health costs. For example, in relation to cancer, alcohol has been clearly demonstrated to have a significant impact on cancer and on cancer-related deaths. It's therefore clearly appropriate that alcohol is included as a priority area in the recently launched National Preventive Health Strategy. This work was funded by the Australian Government Department of Health, and we also drew on their expertise and support. It was developed by an expert team from the National Drug Research Institute, the National Centre for Education Training on Addiction, and particularly from the South Australian Centre for Economic Studies at the University of Adelaide. The draft report was reviewed by 2 peer reviewers, one with expertise in health economics and one with expertise in addiction medicine. We'll now have 2 presentations from Will Gilmore and then from Robert Tate, and then from other members of the team, including myself and Tanya, will respond to questions that are submitted via chat. So when we get to the questions, we ask that you submit them by chat. And we will record the session, but we won't record the question section. We'll record the session so that others who can't make it today can actually see it later on, or you can go back and have a look. And we'll, as I said, we also indicate that you can get the report online. Just before I hand over to Will, I particularly want to thank one of our team who's about to leave us, Akif Mukhtar, who's been a member of the NDRI team. And he's leaving to go on to better and bigger things in the WA government. We wish him well as he heads over to that new role. So thank you, Akif. And now I'm going to hand over to Will Gilmore.
Okay, thanks, Steve. So I'm going to be giving an overview of alcohol's contribution to morbidity and mortality. Just bear with me a second while my screen catches up with me. I can't seem to change the slides.
Try clicking on the PowerPoint icon at the bottom of the screen in the menu bar.
Okay, there we go. Doesn't seem to be. Oh, okay, now we're rolling. Okay, so hospitalization and death data are central to estimating alcohol's burden of disease. So for this analysis, we sourced 2017-18 financial year data on both hospitalizations and deaths from the AIHW and the Australian Coordinating Registry of Deaths. We've used lists of established alcohol attributable health conditions. They're conditions where alcohol is deemed a causal factor and identified through ICD-10 codes in the data. So for the hospitalization data, that's through the primary diagnosis and external cause codes, and it's the underlying cause of death in the mortality data. We took an alcohol attributable fraction approach, which is standard in epidemiology. Lots of people will be familiar with this already, and I won't go into too much detail. But here we basically apply a fraction to each hospitalization or death, and this is based on whether alcohol caused the condition or whether it partially caused the condition. We also, as Steve mentioned, we've got fairly conservative estimates for the social costs of alcohol, but we've put some bounds around our estimates. So based on the protective effect of alcohol on cardiovascular disease, there are various methods of calculating that based on the literature. So what we've done is we've calculated low and central estimates, and they're based on the protective effects of alcohol. And the high estimate is where we assume there is no protective effect of alcohol, which means that the estimate is a lot higher. The central estimate is what we've presented as our main estimate throughout the report, and that's what I'll be reporting in the next few slides, and what I think Robert is presenting when we get over to him. So there's a wide range of alcohol attributable health conditions. We've grouped them into 7 broad categories here. If you look at the cancers there that alcohol causes, you can pretty much see that everything alcohol touches is involved in the outcomes, and so we've got everything from oral cavity or pharynx cancer down to pancreatic cancer and colorectal. All of the cancers are partially attributable to alcohol, but if you look at the neuropsychiatric conditions there in the bottom right, these are mostly wholly attributable to alcohol, so things like alcohol dependence and alcohol abuse, and the one exception there is epilepsy. So our central estimates for the counts of hospitalizations and deaths are that we had 127,000 hospitalizations in 17-18 and around 5,000 deaths. And you can see there that males, in line with the fact they drink more on average than females, they make up about 3/4 of the deaths and hospitalizations. So in terms of the leading causes of hospitalization, you'll see that neuropsychiatric conditions and unintentional injuries are common across all 3 age groups there, coming out in the top 2. And the differences across age groups there are, for the youngest group, we've got intentional injuries, which includes assault and self-harm. Digestive diseases come in for the middle age groups. That includes things like alcohol-related liver disease, and cancers come up in the leading causes for the 65 plus. In terms of causes of death, cancers, digestive diseases, and injury make up around 80% of the deaths. And you'll see we do have a negative figure there for endocrine conditions. That's only about 3% of the total, and that's because of the protective effect for diabetes type 2. So now on to calculating the costs. So in terms of the hospitalization data, each hospitalization has a DRG code attached to it. That's a diagnostic related group code. And the calculation is that we get an average cost of a hospitalization from the Independent Hospital Pricing Authority. Each condition has a treatment weighting, and we multiply these with the count of hospitalizations to get a figure. So you'll see there that we've costed hospitalizations in 2017-18 at 717 million, and that's 2.4% of all hospital costs. So you'll see the guy in the bottom right there, I think his treatment waiting was probably quite a lot. It looks like strangulation by your own tie means you get a double whiskey in the hospital, so that may well have made that one quite expensive. So moving on to premature deaths, these are a bit more complicated. We have both tangible and intangible costs for premature death. The methods we use here are looking at years of working life lost. So over all of the death data, we had 117,000 years of life lost, and that translated to 19,000 years of working life lost. So with data sourced from the ABS and the AIHW and also the Department of Finance, we were able to make estimates of the cost based on lost labor, and that's through paid and household labor, employer costs based on how much it costs an employer to replace an employee when they no longer work there, and there were also avoided healthcare costs. And this came out a total of 2.6 billion. In terms of the intangible costs, this is based on evaluation of premature deaths using a concept called value of a statistical life. And this concept's based on society's willingness to pay to reduce risk. So that includes things like the additional price someone's willing to pay to get more safety features on a car, or a higher wage sought for a job that might have a higher risk of premature mortality. There are different values of a statistical life in the literature, and we've used the different values and paired those with our different methods for accounting for protective effects of alcohol, and came out with a central figure of 26 billion. So I've got to the end of my section, and I'll be passing you on to Robert now. I've heard that he might be testing you on the figures along the way, so I hope you've been keeping a running total. So now over to Robert.
Okay, I'd like to start by paying my respects to the traditional owners of the land and their elders, past, present, and emerging. Unfortunately, I had hoped to go through all the other cost areas we addressed, but there simply isn't time. So what I'm going to have to do is give you some examples and just whet your appetite with those. In some areas, we use 3 different methods calculating that: low, middle, and upper bounds. Some areas we weren't able to do that. We've just calculated 1 or 2 estimates rather than all 3. There are also a range of different data sources that we used, but an important thing to consider here is the issue of double counting. So Will's just talked about the cost of alcohol-related deaths. Clearly, road traffic accidents, workplace accidents are going to include deaths. So we need to exclude those when we analyse these data. I'm going to be looking briefly at other health costs. We're going to look at the criminal justice system, workplace costs, road traffic crashes, the cost of alcohol purchases, but only by people who are dependent on alcohol. We'll come to that reasoning for that later. And we'll also look at the lost quality of life from people who've actually got alcohol dependence. Since our previous cost studies, a new data source has become available by the AIHW, the Disease Expenditure Survey. And if you're interested in health costs, I'd really recommend looking at this. It seems to be a very important bit of data as far as I'm concerned. So as well as reporting on costs to hospital inpatients, it also looks at other cost buckets, things like the emergency department, non-admitted patients, primary care, and so forth. But it doesn't cover all the other health areas. It doesn't cover ambulance cost, community mental health, aged care, or informal carers. And then what the DES does is...
Sorry, Robert, your slides aren't showing, so you need to share.
Thank you for that. Why aren't my slides showing? That's good. Okay, let's try sharing that. Slide. Okay, is that sharing now, Steve?
That's showing, yeah.
Okay. So thank you very much for that. So what the DES does is it maps onto those cost areas, so the emergency department and so forth, by Australian burden of disease groups. So we first needed to look at the alcohol attributable conditions and map those onto the Australian burden of disease groups. Some areas that's easy, so liver cancer is a single group within the Australian burden of disease. We know the attributable fraction for that in terms of hospital separations is 15.8%. So we then apply that 15.8% to each of those cost buckets that the DES reports on. Obviously, that's very a good logic for that at things like the emergency department. Maybe less accurate when you get further away and do things like dentistry and imaging, but that's how we've done it. There are some areas that's slightly more complicated. For example, in terms of alcohol attributable conditions, diabetes 2 is an alcohol attributable condition, but the Australian burden of disease includes gestational diabetes with that. So we only apply a fraction to that cost bucket representing diabetes 2, not the gestational diabetes. In other places, we've had to use other methods. So we took the 2.44% of hospital separations attributable to alcohol and applied that to each of the cost buckets. And finally, for some of our estimates, we had to use a different sort of direct estimation. For example, emergency departments, nearly 26% of all presentations are alcohol related. And then we report the high, central and low estimates from there. I'm just going to give you a couple of examples, one using the DES and one not using the DES. So we know the total cost of PBS medications, including the RPBS, is 13.1 billion. In estimating the high bound, we use that simple approach of the 0.244%, the hospital separation cost due to alcohol, and that gives us a total figure there of $318 million. For the low bound, we applied the attributable fraction for each condition. So again, using liver cancer as an example, the DES reports that within the PBS, liver cancer accounts for $2.1 million of drugs. Apply the attributable fraction of 15.8%, gives you a total spend on liver cancer attributable to alcohol of 195,000. Do that for each condition and you come to a total just over $100 million. And in this case, our central estimate was just the mean of those two values. Now looking at an area where we didn't have that DES data, and these the figures for the aged care system come from the Review of Government Services. Just a note here that in our previous estimates, we've excluded people with dementia in any of these levels of aged care. The rationale for that was that whatever other conditions you had, if you had dementia, you would be in aged care, if you were in aged care with the condition. And here we were only able to estimate one value, and that was the central estimate, and we applied the 2.44% to that non-dementia total cost. And that gave us a total cost for aged care of 210 million was alcohol attributable. But clearly, there's a limitation I need to acknowledge here that some cases of dementia are going to be alcohol attributable. In fact, there are estimates that might be between 10 and 24% of the cases in residential care. So our estimate there is definitely likely to be an underestimate. Just want to run through a couple of the figures in the healthcare system for you. Obviously, the hospital separations are the biggest cost bucket in this area at over 700 million. Primary healthcare, that covers both referred and unreferred services, over 400 million. In terms of the proportion of the spend that was due to alcohol, the biggest area is drug treatment services. So over a third of the cost in drug treatment services is due to alcohol use, which I imagine that for many of you working in the sector, that's not going to be a surprise. And the total cost to the alcohol to the health sector of alcohol use is 1.6%. Now, despite alcohol being a legal drug, of course, it's involved in a number of problems in the criminal justice system. So the first thing we had to do was develop the conceptual equivalent of attributable fractions. I'm sure that many of you are aware of the Drug Use Monitoring Australia data, DUMA data, and this method's been used before. What DUMA does is conducts interviews with police detainees in a selection of police stations, but there are some limitations to cover here. Firstly, it only covers a limited population. It's a small survey. It only covers adult data. But although it has these limitations, it has been used repeatedly with this method. Police detainees are asked to attribute their most serious offence. So if you've got multiple offences, they ask you about the most serious category of offence, and then you are asked to attribute how much of the offence is due to alcohol, or they also ask about other drugs. So looking at this table here, we're saying that 18% of violent offences have been attributed to alcohol use. Then we have to decide how much of those each offence should be costed when it comes to the total police budget. Well, firstly, there are different complexities in prosecuting crimes. We weighted these by the amount of time it takes to prosecute crimes of this case, of these types in court. And from that, you can see that there's a greater weighting on violent offences than, for example, on traffic offences. On average, it's harder to prosecute one than the other. We also don't take the full police budget because not all police time is spent on crime. And there are two estimates here, that between 64 and 80% of police time spent dealing with crime. And of course, just to reiterate, this is only on adult crime, so we've reduced it down to that 87%. Putting that together, you get a total cost for, say, violent crime there of just over $2 billion. Then you apply the attributable fraction, 18% of that, to give you $363 million due to alcohol-related violent crime. And you can see in the bottom right corner, that total comes to just over $1 billion as alcohol attributable. We then use that same method of attributable fractions throughout the criminal justice system, and had to apply different corrections as we went through. For example, the most obvious one, it's a lot more expensive running the higher courts than it is magistrates' courts. And we took that into account in calculating these figures. And I also just want to note there that imprisonment, again, a very expensive area, but there are some savings. So we're talking about a net cost here. So government benefits aren't paid while you're in prison. And finally, we weren't able to cost estimates for the liquor, gaming and racing regulation aspect of these times. Another very important area to consider is the cost of victims of crime. So there are two types of crime we've identified here. So those attacks on a person, so physical assault, sexual assault, and also household crime, so breaking and entering, theft and so forth. And the figures down the right-hand column combine both tangible and intangible aspects. So if your house is broken into, there's the lost value of some goods that are stolen, but there's also a reduced quality of life from that breaking and entering and the feeling of violation. Putting those all together, we can see that imprisonment is the single biggest area at over 31% of the costs, with police being the second biggest area. But if you look at the costs to victims of crime in terms of personal and household, if you combine those, they would be the single biggest area. As Steve said earlier, we collaborated with our colleagues at Encita on this project, and this was their particular area of expertise that they made the vast majority of this work is by them. They calculated costs relating to alcohol-related injury and alcohol-related absenteeism. The occupational injury data came from WorkSafe Australia, and back in 2012, 2013, there were 375,000 injuries, and just for your information there were 400 deaths. But of course, we're excluding those, we're not counting any cost here for those deaths, they're attributed elsewhere. And the same with work-related road traffic accidents. Back in 2012-13, the cost was 26 billion, with CPI increased that to 28 billion. Now, these injuries cover both workplace compensatable and non-compensatable injuries, and the attributable fractions that we applied were those there. The absenteeism data came from the National Drug Strategy Household Survey, and they allow two estimates to be made, one for absenteeism due to general injury or illness, and then there's another question on specific alcohol-related absenteeism. And their analysis controlled for, as you can see there, age, sex, marital status, and so forth. And what they were looking for was excess absenteeism, so the number of additional days. So for all cause, that's the difference between abstainers and consumers, there were 15.8 million days, and for alcohol specific, that's 3.3 million days, and that compared people who were low risk consumers versus high risk. And those definitions of low and high risk were derived from the National Drug Strategy Household Survey. We then applied the attributable fraction to those costs we just calculated there, and that gives you a central estimate of $0.4 billion for alcohol-related injury. And similarly, we applied the attributable fractions there, and you get the low and high range with a central estimate of 3.6 billion. Steve did touch on the issue of presenteeism. So if you turn up at work intoxicated or with a hangover or reduced performance due to poor health, then there is a cost of that. However, we didn't think the data was actually good enough for Australia to include that in our overall total. So here we've estimated it at approximately 5 billion, but we haven't included that in our overall total. I'm sure you're all aware of the impact of alcohol on road traffic accidents. If you've got blood alcohol of above 0.05, 23% of drivers who are involved in fatal crashes have that high blood alcohol level, and there's also increased level of culpability for people involved in accidents. There are a limited number of costs we examined here. We didn't include the lives lost or the hospital separations, so we're looking at things like insurance costs, property damage, and so forth. Again, the data in this area is really pretty dated. This comes from the Bureau of Infrastructure, Transportation and Regional Economics, I think I got that right. And they identified over 650,000 alcohol crashes, nearly 250,000 alcohol crash injuries, and again, just for your information there, about 1,600 alcohol crash deaths. In terms of the short-term costs, we just used the bright figures and updated those. For long-term care costs, we used two sets of data. There's Victorian data on compensation payments made to people involved in crashes, which we used for the low bound and extrapolated that to national figures. And the high bound, we used, again, bright and updated that. And they report on the level of compensation by level of severity of injury. Put those all together, and the total cost of road crashes was $3.4 billion. Clearly, there's some limitations that need to be considered here. This really doesn't address minor accidents, which don't get reported very well. Those bright figures are very dated. Although we did adjust them by CPI, we also had to adjust them to address the increasing number of people who are driving compared to in 2006. We also looked at alcohol purchases. In general, you don't consider people's purchasing decisions in social cost studies. That basic theory tells you that what you pay for something, you will receive a benefit from it, you're anticipating a benefit from it, and you anticipate that that benefit will be at least as much as you pay for it. Now, it's arguable that people who are dependent on a drug, alcohol or anything else, don't have fully rational decisions. That's not saying they can't make rational decisions, that's saying there are other things as well as the benefits that they're going to obtain from their alcohol use. For example, a lot of people say they want to quit using, for example, tobacco or illicit drugs or alcohol, but they're unable to. So on that basis that we're calculating the cost for alcohol purchases for people who are dependent. From the global burden of disease, this is where the figure of the number of people with alcohol dependence comes from, nearly 500,000 people, and that's about 2.39% of Australian adults. From my colleagues in Melbourne, this paper reports on how much alcohol is drunk by the top 5% of drinkers. They consume 37% of alcohol. From the ABS, we know that spending on alcohol is about 16 billion a year, and we apply that 37% to 16 billion, gives us nearly 6 billion a year on alcohol spent by the top 5%. However, it's important to recognise that people who are the heaviest consumers tend to buy, on average, cheaper alcohol than the lighter consumers. And these were the figures reported by Livingston and Callahan. So the average price in the top 5% was $1.47 versus $1.81 per standard drink for their alcohol. So you need to factor that in. Also, you need to remove the cost of taxes and duties because they're not part of social costs, they're transfer payments. Removing the cost of GST is easy. Other taxes, I'm sure anyone who's looked at alcohol taxes realizes just how incredibly complex they are. So we've used a very crude figure here. We've just said that we've taken the portion of spending by those in the top 5% and removed that. That gave us an overall figure of 1.1 billion by 2.39%. Those who are dependent. Now, clearly that assumes that they drink the same quantity of alcohol across all the people in that top 5% and that they pay the same amount as the average amount for those top 5%. Finally, I'd just like to say a little bit about the lost quality of life for people with alcohol dependence. And this is done in terms of disability adjusted life years, and it's reported by the global burden of disease. And there you can see the central, low and high bound for the number of disability adjusted life years lost. We'll only report on the central estimate of the values that we applied. So the central estimate was 309,000. A low bound estimate, this comes from an estimate of what the PBS will pay for new drugs, $47,000 for a low bound estimate, and the high bound estimate comes from American data. Put those figures together and you get for the 67,000 lost years of life, that's $20.7 billion. Now there is some overlap here with premature mortality. So the global burden of disease says there are about 580 deaths due to alcohol dependence. We had over 5,000 deaths due to alcohol use disorders, so it's about 1/10 of the number of deaths at some overlap. Just a final summary here. As you can see, most of the costs, nearly 73%, are those intangible costs. The major costs in terms of tangible were workplace costs at 22%, followed by crime and healthcare. Just want to say a little bit about the ranges, so I've just highlighted some figures here. There's actually a pretty big range in terms of the values that we report, and we'll only focus on the central estimate. Looking at the bottom half there, those figures for premature mortality and morbidity, it is somewhat arbitrary, the values you choose for a statistical life. There's a rationale for that choice, but the values you choose for them are somewhat arbitrary. So that explains why there's such a big range there. You could choose other values which would make that larger or smaller. In terms of the range for the workplace costs, that's due to the standard error in the National Drug Strategy Household Survey, and then applying that to national data to get the population levels. Steve touched on this. These were areas that we identified where there are harms, but we didn't think the data was good enough to include them in our figures for Australia. Just a final couple of comments to make that apply to all cost of illness studies. We're working from administrative data. It's not put together in terms of doing these calculations. A number of places we've had to generalize from a sample of the population, so that Victorian data on compensation payments we had to apply to the national data. We're missing data in some areas, so federal police, we had no data on that. Juvenile crime, there's some very old data on that which we didn't use. I've just been talking about the wide range of estimates. Co-use of drugs, we know that for some conditions, for example, some of the cancers, combining alcohol and smoking increases the risks there, so that's probably going to affect that. And also, the cost of illness is based on the idea that if that drug is removed, these costs would disappear. I can't imagine a world where alcohol isn't available in some situations, so I find that hard to follow through the rationale what would happen if alcohol was removed. We've seen what happens in America when prohibition was applied, that it doesn't get rid of it from the system. And finally, there's a number of data sources that we need to acknowledge and help that we need to acknowledge. So I should now be handing you over to Tanya to talk through the implications of our findings.
Thank you very much, Robert. Can you all hear me? Robert, give me a thumbs up. I can see you. Good, yep. Excellent. Thank you. Hi, everyone. My name's Tanya Chikritzhs, and I head the Alcohol Policy Research Program at NDRI. I'm a co-author on this report. And before we go into question time, I've been allotted a few minutes to do a sort of big picture / discussant sum up of the report, which is kind of weird for a co-author to do, but never mind that for the moment. First off, a very big thank you to Robert and Will for managing to condense an enormous amount of complex work into, I think, 35 minutes or less. I also want to personally acknowledge the fantastic work of our economists who aren't here presenting today, but who are obviously central to this work. I have enormous admiration for Steve Wetton, who I've worked with on various cost studies over the years, and he is a true champion of his profession. So it is with great respect to economists everywhere that I'd like to begin my 5-minute slot with a brief reflection on the two incontrovertible laws of economics. And the first, many of you will be familiar with, as it states that for every economist, there exists an equal and opposite economist. And the second law, of course, which states that they are both wrong. But in my experience, the very best economists have very clear sight of all the assumptions that they make along the way, and they will fight to the death to defend them, and they'll document them very clearly. And certainly Steve Wetton has done that perfectly in all of the reports that he's been involved with. It's also very fortunate that when costing, the costs of human behaviours that influence health, economists, sorry, my phone's pinging, hope you can't hear it, sorry. that economists can rely on epidemiologists like myself to give them plenty of material to make assumptions about. So in case you missed it, a key characteristic of social cost studies is that they marry together economics and epidemiology. So that is to say that for those among us and who have a predisposition to value certainty above all else, which is fine, there really is no more diabolical union in science than that formed between economics and epidemiology. It's just a fact. Social cost studies are not for the faint-hearted. It's true, their foundations must be built on the best available evidence, but in order to progress the field, they really must have bold aspirations. And I think that's what we've done in this work, is to begin with very bold aspirations. We tried to do a lot, and we discovered along the way that we couldn't do it all. Which brings me to my first point. So although all the dollar signs in these reports and on the slides create the illusion that social cost studies are all about costs, in actuality, it's all about epidemiology. That's which forms the foundation. That means that when the epi falls short of our aspirations, you can bet your bottom dollar that it's going to have implications for the econ side of things. So our approach to acknowledging and trying to deal with some of this inevitable variability and uncertainty, especially when the underlying epi continues to evolve, was, as Will pointed out, was to make not one estimate, but 3 estimates for each of our key domains. So we decided at the outset that it was absolutely crucial that our best estimates would be placed within a range of lower and upper best estimates, which relied on alternative assumptions. So as Robert's described to you, we give you a central estimate of 66.8 billion, let's call it 67 billion, and we nest that within an upper bound that says, well, the total may well be over 3 times larger than that 67 billion. And then we give you a low bound as well, which says, well, at its lowest, most conservative end, it may only be half as much. It's still an enormous amount of money. This created, of course, a whole lot more work for us, which was a little bit crazy, but ultimately, and we hope you agree, it's produced a better product and is an advancement on previous efforts. Of course, then, just as you're getting the hang of how we deal with uncertainty in the report, I presume you're going to read it or you've read it already, which is fantastic, but we throw you a curveball and say, but wait, there's more. We've also made a suite of other estimates, some of them pretty important, with pretty important outcomes, but sorry to say that in the end, we didn't include them in our final total because the data or the methods available at the time just aren't up to scratch. So FASD is the one that absolutely stands out there, and it was our intention to include FASD costs in our central estimate, but we were hamstrung ultimately by the lack of suitable general population prevalence data in Australia, fundamental information we just don't have right now. What we did do was make what we term a tentative estimate based on US and Canadian studies, and we came up with a value that ranged somewhere between $14 and $23 billion a year. So at the top range, what's that? Almost a third of the total that we've given you today. So the key message in that is that both the social impact of FASD and the absence of Australia-wide prevalence data are not trivial problems, and we need to deal with those at a fundamental level. It also says, of course, that there is a very strong likelihood that our central total of 67 billion is a very serious underestimate. Indeed, if you sum together the total of the tentative estimates, 3 main biggies, so FASD, Presenteeism, and the intangible costs to families and partners living with somebody with alcohol dependence, then that's potentially another 43 billion on top as our central estimate. So we're getting close to 100 billion if we were to add that, but we haven't, right? So we weren't confident enough in the data sources and the methods to make that a solid commitment in the report. Which leads me to my second point, and you'll find that the report pays a great deal of attention to documenting assumptions and limitations, and that's for very good reason. So as Robert said, you've got to keep in mind with all social cost studies, that they suffer from the overarching limitation of having to rely on data that other people collected, so administrative data. And these data are rarely designed with a view to help out epidemiologists and economists running cost studies, and they have enormous variability in what they record and how they record it. And that means that some of our cost domains needed to have a whole lot more assumptions than others, some not so much. So for hospital separations are great, for example. So it's not only the case that a hospital episode is nice and tightly bound to its average cost, but that data set comes, thanks to federal funding, with a DRG that's attached to a cost weight, which lets us estimate average costs, which is beautiful. Actually, it's very easy. By comparison, when costing police and criminal justice systems, and I see we have a lot of police today, we had to use a series of assumptions to estimate how much of the budget of different police budgets that we're able to allocate to each type of event or outcome. So, for instance, I think this was particularly difficult to do. In fact, we may have even left costs out altogether when we were talking about the Australian Federal Police time spent on alcohol-related events, Australian Border Force, and the Federal Court. Robert can correct me if I'm wrong later. And of course, there are also domains where harms and costs clearly arise, and we talked about them before, such as the quality of life for children and partners of dependent drinkers, or maybe not even dependent drinkers, maybe just risky drinkers who drink to intoxication routinely, where we know there's harm, but we just don't have enough information to ensure that if we do include our costs, and we did calculate them using a different method, in fact, relying on disability adjusted life years, but if we did include them, there's too great a risk of double counting. So we had no way of making sure that when we added in those disability adjusted life years, that we wouldn't be doubling up on costs that were already embedded somewhere else, such as in violent crime or child abuse estimates. Right, so I think that's pretty much my 5 minutes up, and if I keep going, I'll spoil all the fun for you anyway. So I'm sure you'll all read this 170-page report from top to bottom. But rest assured, for those of you who are uncomfortable with lack of certainty or exactitude, that there's an abundance of transparency in this report that hopefully provides some adequate compensation. Right, so throwing to Steve, I think, to organise questions if we still have time.
Thanks, Tanya. And I've also just used chat to send the link to not just the alcohol report, but all the other reports. So if people want to go to the reports, the